Hello everyone, my name is Lana Misak. I am a critical care nurse and nursing educator, and I'm here today to talk to you about care of the hemodialysis patient in the critical care units. As many of you know, the incidence of renal failure is climbing here in the United States, which means that we also have an increased incidence of patients who are receiving hemodialysis. And I'd like to talk to you today about a specific population in the critical care units that we are seeing so that we can improve some of these patient outcomes. So what we're going to talk about today is the adverse events that are associated with hemodialysis in the critical care, and then we're going to also talk about the considerations of hemodialysis within the patient populations of cerebral infarct or injury, with patients with respiratory insufficiency, with our CABG and PCI patient population, and the septic patient. We will also talk about some nursing interventions for the patients who are receiving conventional hemodialysis in the critical care unit, and we will talk about ways to improve the communication between the hemodialysis nurse and the critical care nurse. So first, let's talk a little bit about hemodialysis. In 2015, the number of patients with end-stage renal disease had climbed to approximately 660,000. 400,000 of these patients were receiving maintenance dialysis and had a high hospitalization rate, high mortality rate, and poor quality of life. In fact, the mortality rate of these patients remains more than 20% a year, which is 10 times greater than the general population. Hemodialysis is associated with hyperphosphatemia, chronic inflammation, vascular calcification, accelerated atherosclerosis, vascular stiffness, and even cardiac ischemia. So as a critical care nurse taking care of dialysis patients, one of my primary concerns has always been hypotension. What I was not aware of is that there are two kinds of hypotension in this population. One is preload dependent hypotension and the other is non-preload dependent hypotension. With preload dependent hypotension, it is an increased risk with the mechanical ventilated patient, which is the majority of our patient population in the critical care units. There is an increased plasma capillary leak and alterations within their systemic venous return system. Non-preload dependent hypotension usually is associated with some pre-existing cardiovascular diseases, and it can lead to organ dysfunction. Any hypotension occurring during hemodialysis doesn't necessarily mean that we have to discontinue fluid removal, but we should actually be prompted to look at the hemodynamic evaluation of the cardiovascular status of these patients. So some other possible adverse events during hemodialysis are air embolism, malignant arrhythmias, myocardial infarct, and cardiac arrest. Only 7% of every 7 out of every 100,000 patients receiving hemodialysis actually do experience cardiac arrest. Many of these adverse events are associated with cardiovascular disease, left ventricular hypertrophy, rapid electrolyte shifts during their hemodialysis session, some sympathetic overactivity that is occurring, and cardiovascular deposition of calcium phosphate. We also have dialysis disequilibrium syndrome. This is a very rare syndrome that typically occurs during the first dialysis session that patients are experiencing, and it is characterized by nausea, vomiting, headache, encephalopathy, and seizure activity. Other possible adverse events are hemolysis, HIT, which is heparin-induced thrombocytopenia, venous needle dislodgement, which can result in hemorrhagic shock, and then they can also experience some allergic reactions, both type A and type B, which are anaphylactic or cell-mediated. Some more common conditions associated with hemodialysis are muscle cramping, itching, nausea, anemia, pericarditis, and then some access site issues such as bleeding, infection, aneurysm, and blockage. So now let's talk about some of the most common diagnoses within the critical care department and how these are related to hemodialysis. The most common critical care diagnosis that we see are respiratory insufficiency or respiratory failure, intracranial hemorrhage or cerebral infarct, coronary artery bypass grafting or percutaneous coronary interventions, and sepsis. So first, let's talk about respiratory insufficiency or respiratory failure with our hemodialysis population. Typically, this is seen in patients with a severe underlying pulmonary abnormality where routine dialysis prescriptions may not necessarily be tolerated. Some of these patients experience a rapid correction in acidosis. In this patient population, the dialysis is often associated with the acid-base shift to overcome their respiratory compensation. There's acute hypercapnia, respiratory failure that is triggered by the rapid bicarb influx from the dialysis. There's an acute rise in the pH, which can cause hypoventilation and respiratory depression. There's alkalosis-induced tissue hypoxemia. And there's an abrupt reduction in the circulating hydrogen that is neutralized by the bicarbonate, and it reduces the ionized calcium and can lead to hypocalcemia. It can also result in neuromuscular and end organ impairment and even diaphragmatic muscle weakness within the respiratory system. So what should we be doing for these patients to prevent these respiratory insufficiency and failures during hemodialysis? Patients should receive judicious adjustments of the dialysate bicarbonate concentration. So, of course, this is up to the nephrologist and the dialysate orders, but we do have to be careful about the dialysate bicarbonate concentration with this patient population. Next, we'll talk about cerebral infarcts and insults with hemodialysis. So, with this patient population, there's a great risk of cerebral edema and hypoperfusion during hemodialysis. This can cause a recurrent ischemic episodes during the dialysis or shortly following the dialysis. Patients with stage 3 through 5 kidney disease have an elevated risk of stroke compared to those of non-chronic kidney disease. And risk increases further during the first year after hemodialysis is initiated after this patient population. So with this patient population, we need to consider shorter, more frequent hemodialysis sessions. We should be considering oxygen during their dialysis session, especially with patients who have COPD. And we should also be using compression stockings or leg pumps to increase cerebral perfusion during hemodialysis. Next, let's talk about hemodialysis and the coronary artery bypass grafting and percutaneous coronary interventions. So, acute kidney injury post-CABG or PCI. Acute kidney injury following cardiac surgery is frequent cause of major morbidity and mortality. And early replacement therapy, pre-op or even during that first post-op day, achieves a significantly lower mortality rate. You can see here it's 22% when you compare it to starting just 2.5 days after surgery, which is as great as 43%. So the earlier renal replacement therapy, the better outcome for these folks. So we also have to consider fluid overload and pulmonary congestion after a CABG or PCI. It's related to cardiopulmonary bypass, anemia, any bleeding tendencies should also be considered. Patients undergoing hemodialysis are at a higher risk of infection as well, such as pneumonia, kidney failure, bloodstream infections, and cellulitis. And then there is an increased risk for non-occlusive mesenteric ischemia and vasospasms as well. This is increased incidence in patients with episodes of hypotension and excessive ultrafiltration and rapid filtration rates that can cause ischemia. So next we'll talk about hemodialysis and the sepsis patient. So sepsis is the second leading cause of death in patients with end-stage renal disease. And sepsis is 100 to 3 times higher for chronic dialysis patients. They have a lower respiratory tract infections are the most common cause of bacteremia with these patients. And hypotensive, weak, end-stage renal patients usually, presenting from dialysis They're usually diagnosed with hypovolemia, which can often lead you to believe it's hypovolemia when actually it is sepsis. So now we'll talk about nursing care for this patient population. So of course we want to make sure that we're getting daily weights and we're doing accurate intake and outtakes. We'd like to CVP monitor if possible and hemodynamic monitoring. And we also need to pay attention to fluid management as well with these patients. We want to monitor their electrolytes and we want to report any abnormals promptly to physicians. We want to avoid and treat hypokalemia and hypocalcemia as ordered. And we want to initiate renal replacement therapy promptly. Internal jugular access is recommended for a short term. We also need to avoid subclavian and peripherally inserted central catheters as well for these folks. We need to maintain clean dressing over the access site and perform our dressing changes as per our policy. And avoid venipunctures or placement of ID bands and restraints over patients' fistulas. We also want to pay attention and monitor for bleeding precautions due to their platelet dysfunction. Now we'll talk about some pharmaceutical recommendations and considerations. Patients who are on medications such as propofol, Versed, morphine, or fentanyl should be cautioned, especially when we're titrating these medications, because their elimination capabilities are altered during hemodialysis. We need to also avoid undertreatment and non-therapeutic doses of our antibiotic therapies, which at most facilities, the pharmacists are very good at monitoring that, but we also need to be aware that those medications may need to be adjusted for this patient population. We also need to collaborate with pharmacy and the hemodialysis nurse about medication administration during dialysis, as these are our resources to know what should and should not be given during dialysis. So collaboration and care. So we'll talk about expectations of the dialysis nurse in the critical care unit. The dialysis nurse should communicate with the room nurse on the patient's status and concerns of hemodynamic instability, as should the room nurse collaborate with the dialysis nurse. They need to assess the patient prior to the dialysis session and evaluate the patient's level of dialysis care. They need to be responsible for the patient's hemodialysis session and communicate with the nephrologist regarding the patient's care. Will report concerns to the room nurse and remain with the patient at all times during the dialysis session. The dialysis nurse must also be readily available to assist a technician if a technician is the one that is running the dialysis. So now let's talk about the expectations of the dialysis technician in the critical care. The dialysis technician should introduce himself with their credentials so that the room nurse knows that they are a technician and not indeed a dialysis nurse. They should communicate to the room nurse on the patient's status, as the patient's nurse should communicate the patient's status to them. They are responsible for the infusion therapy and the hemodialysis machine. They should be reporting any concerns to the room nurse immediately and contacting their supervising dialysis nurse if they have any problems. They must also remain with the patient at all times when they're performing the hemodialysis session. So again, collaboration and communication with the dialysis nurse should involve the patient's condition, any health concerns that we have, the dialysis orders, the previous dialysis complication or tolerance or intolerance that the patient has had, and any ordered medications. Any questions that you have, you can leave below on the YouTube video here, and I can get back with you to answer any of those. And this completes care of the hemodialysis patient in the critical care, improving patient outcomes. Thank you for your time.